السلام عليكم Adnan. Can you hear me?
Walaikum salam. Yeah, we can hear you and you can see us right.
Can we start? With,
Ni ugonjwa.
uh, Adnan, can we start or we give some more minutes?
We can start.
Okay, thank you. Today we're going to discuss hematology, transfusion, and blood component sport. My name is Abdurrahman Isaq. I'm a level 4 MPCHP. I hope I'm very much clear. Okay.
Yes, Andy.
Today, the scope of the discussion will be we will revise about the transfusion, the various blood components, and go through hemostasis and the coagulation cascade, and look at the various tests, the coagulation profile, the bleeding time, the prothrombin time, the APTT, and the thrombin time, if time allows us. And we look at some examples as well. Okay, starting with the blood components, I just wanted to show here the various ways we can obtain the various blood components we can obtain once once the blood is donated. First, the various tests to be done after donation. For screening, we screen for HIV, the viruses, hepatitis C, hepatitis B, syphilis, and the various tests. Can anyone uh, list for us the various components we can get from blood? We have packed red cells, fresh frozen plasma, cryoprecipitates, and the others. I just wanted to show here how we can obtain them. I'm not sure they are very much testable in terms of sports, the procedures as well. Okay, before going on, I want us to be very interactive to make maximal maximum importance out of it. Okay. The first component we will look at is the fresh frozen plasma. Can anyone unmute and tell us about the uses and what they entail? Hello? Anyone can unmute and chip in?
I can try.
Yeah, go ahead.
Okay, so for the fresh frozen plasma, for the indications, for example, when you have maybe hemorrhagic disease of the neonates, We have if someone has like warfarin overdose. There's also DIC. Yeah.
Okay. What factors does it contain before going to the indications first? We can have.
Okay. It contains all the anticoagulant factors, all of them.
Okay.
Yeah.
What about cryoprecipitate?
For the cryoprecipitate, it has the factor 8, von Willebrand factor, factor 13, and the fibrinogen.
Okay, thank you. In a spot, you can also be given the picture and ask what are the, the storage temperatures that they are stored at. Can anyone try as well? Anyone? Okay, we will see. Okay, thank you. Thank you. For the fresh frozen plasma, just like our colleague said, it contains all the factors: factor 2, factor 5, factor 10, factor 8, factor 9, factor 10, factor 11. It's used for vitamin K when all the factors are depleted, like in liver failure, like in vitamin K deficiency, because the vitamin K deficiency, in vitamin K deficiency, production of those factors are limited. The factors limited in vitamin K deficiency are factor 2, factor 7, factor 9, and factor 10. Okay. For the temperature, I didn't indicate here, but just to be clear, it is stored at the negative 18 degrees Celsius. Okay. For cryoprecipitate, it contains factor 2, factor 8, which is also contains von Willebrand factor, and factor 13. The indications are fibrinogen deficiency, which is factor 2, and for hemophilia A, which is the factor 8 deficiency. It can also be used as a hemostat in surgery, which is applied to induce the primary coagulation, which involves factor von Willebrand factor. Okay. And the next spot here is just to show you the whole blood and the different package, the blood bags, the different blood bags. We have the double blood bag, as you can see here, and the triple blood bag. You can be given any. Okay. Can anyone tell us the indications? Let's discuss. For the whole blood, you can be asked the storage, how many days, the components other than blood in that bag, and the volume as well. Can anyone try? Can anyone try? Anyone?
What's the question again? Sorry.
For the blood, the whole blood, we are looking at the whole blood. You can be asked what are the indications for transfusion of whole blood. The components in that blood, in that bag, other than the blood, the preservatives and the storage. How many days you can use? How many days you can store before it expires?
Okay. Oh, okay. So for the indication, maybe something like acute blood loss. You can also have when you're doing a massive transfusion.
Yeah, thank you. Perfect.
Yeah.
Can you try
Hmm?
the preservatives as well?
Okay, so for the preservatives, we use CPDA, the citrate phosphate adenine, and citrate phosphate. Yeah, that one that we keep it. It will keep it for 35 days. The CPDA.
Yeah, thank
you. Yeah.
What about the volume of the bag?
Okay, for 1 unit, it's usually 450 mLs.
Yeah, thank you. Okay, we'll see. For the packed red blood cells, most probably you'll ask about the indication for the packed red blood cells. Can anyone try? Okay, we will see. Okay, thank you for answering. The first one, we were looking at the whole blood. It contains 450 plus or minus 50 ml. Storage, you will use citrate phosphate, adenine, and adenosine for 35 days. If you use sodium citrate, you store for 21 days. For the indication, maybe to correct acute hypovolemia and maybe severe anemia. For the packed red blood cells, we store at 2 to 3 degrees Celsius for 35 days. It has an iron content of 200 milligrams. That is not, it's a nice to know. I don't think you will ask. Indication is basically anemia. 1 unit of packed red blood cells raises the hemoglobin by 1 grams per microliter. Okay. The next one we look at is the platelet-rich plasma. Or anyone try its indications?
Thrombocytopenia.
Okay, perfect. Thank you. Storage, it's at negative 20 to negative 24 degrees Celsius with a shelf life of 5 days. This is this is the component with the least half-life. Its indication is basically to correct thrombocytopenia and prophylactically for stable patient during chemotherapy to prevent bleeding as well. Here I was looking at I was trying to show the difference between the direct and the indirect Coombs test. What are the indications for the Coombs test? Anyone can answer? This one I think you've done in hemolytic anemias as well. The indications of Coombs test.
Just checking for the autoantibodies towards the RBCs.
Okay. In hemolytic anemia, for the autoimmune hemolytic anemias, yeah. Okay. I was here. I was trying to show the difference between the direct and the indirect Coombs test. One of them is used in autoimmune hemolytic anemias. The other one is used in cross-matching. The various tests done before blood transfusions. It's one of them. So I was trying to show this one may be asked for those of you who have done maybe your rotations in hematology. It's one of those frequent questions. For the direct CUM test, we use the patient's blood, the recipient blood as the test sample, and then you add the CUMS reagent, which involves which contains the antiglobulins. So when you add and the patient's blood are when the patient's RBCs have antibodies, when it agglutinates, the result will be positive. If there are no agglutination, the test is negative for hemolysis. For indirect CUM test, we use the patient's serum, and you add the CUMS reagent. If the recipient's RBCs are not, they don't have the antibodies. When they are not sensitized to the antibodies will react with the CUMS reagent to form to agglutinate, which is now positive for the cross-matching. This will show that the recipient's RBCs are already sensitized to the exposed antibodies previously, so it will agglutinate, and there will be no. It will not be compatible with the donor's blood. Okay. Here I was just showing you the difference between the direct and the indirect CUM test. For direct, we use the patient's whole blood. For the indirect, we use the patient's serum. For the indirect, we are looking at the recipient's antibodies in the serum, and for the direct, we are looking at the patient's RBCs in the blood. What are these other screening tests done on the blood before transfusion? We looked at it previously as well. The screening tests. We will screen for HIV, for hepatitis C, and the others as well. Here I was trying to show the blood groups. There are the various blood groups available. Blood group A. For the blood group, we are looking at the antigen and the antibodies and its rhesus as well. Here I was trying to show the various blood groups and its compatible donors and recipients. You can be asked. I hope you can figure that as well, right? You can be asked as well the frequencies of these blood groups in Kenya. As well, when you give blood groups that are not compatible, there will be transfusion reactions which happens, and there are the various as well. You can read about them. Among them, you can read about them: the immediate, the delayed, the immunological, and the non-immunological as well. Okay, let's change gears to hemostasis. These are the cascades. We have the intrinsic pathway and the common path, the extrinsic and the common pathway. The intrinsic pathway, it involves factors 12, 11, factor 10, factor 9, and the extrinsic pathway, it involves factor 7, factor 3, and factor 10. For the common pathway, factor 10, factor 2, and factor 1. Okay, the extrinsic pathway starts, let's start with in the intrinsic pathway. The intrinsic pathway starts with the activation of factor 12 to activated factor 12, and which activates factor factor 11 to activated factor 11, which now activates factor 9 to activated factor 9, which now combines with factor 8 to activate factor 10 to activated factor 8. Factor 10 to activated factor 10. For the extrinsic pathway, extrinsic pathway, the tissue factor, which is factor 3, activates factor 7 to activated factor 7, which now activates factor 10 to activated factor 8 in the presence of phospholipids and calcium. For the common pathway, the activated factor 10 from the intrinsic and the extrinsic pathway activates prothrombin to thrombin, which are factor 2 to factor 2, which now activates factor 13 to activated factor 13, which now forms the stable fibrin plot. You can be given a diagram like this, and they hide one of the factors, and you can be asked to label. Okay. Any questions so far? Okay. From now we are going to look at the various coagulation cascades available, the tests done. The first we are going to look at is the bleeding time. Anyone to try this? Which method of test is this bleeding time? Anyone to try? You can write in the chat box as well. You don't have to unmute me. Okay, what are the other tests for bleeding time? You know. There are 3 of them. Anyone can remember? For those
There
of
is
you,
Duke's template and IVs.
yeah, thank you. There are this Duke's, IVs, and the template. This one is the Duke's method, where we use the yellow. Okay. There's the IVs and the template. For the IVs, we use the forearm. On the flexor part of the forearm, we apply a pressure of about 40 milligrams of mercury, and you cut a slit of like 3 millimeters using the there's the template method where we use a plate cut. Okay, this is the Dukes. Anyone remember the normal ranges for a Duke method at the earlobe to make a clot? How many minutes does it take?
If I could remember well, for Duke was 1 to 5 minutes, and then Ivy was 1 to 9 minutes.
Okay, thank you. Perfect. This is the Duke's method of bleeding time tests. The other methods are we mentioned. Thank you. The Dukes and the IVs and the template. What is the function of the bleeding time? What does the bleeding time show? What does it show when bleeding time is prolonged or shortened?
Okay. Oh, it's used for checking for the primary hemostasis, which basically is checking for the platelet function.
Platelet function as well. Remember, in the formation of the primary the primary hemostasis, the platelet plug we use the von Willebrand factor as well. So it also shows if it is also prolonged in von Willebrand factor deficiencies as well. Okay. Here I was just trying to show the prothrombin time. You can be asked about the prothrombin time. You can be asked what are the ways in reporting, especially. There are four methods in seconds, in index, and in ratio, and in the INR. You can be asked any of those. Especially they like to include ASCO here as one of the choices, which is wrong. In seconds, the test is shown in X and the control is shown in Y. In index, it's a percentage of the test over the control. And in ratio, it's with no units, it's the ratio of the test and the control. And in INR, this is a standardized test of the test over this ratio. It's hard to do, but you can look up as well. You can be given any numbers in you can be given and asked to discuss. You will see ahead. Anyone can comment on this test. Just comment without going without telling us the causes. Just comment for the 1, 2, and 3. If it's prolonged or delayed. You can chat in the chat box as well. Okay, number 1, prolonged. Okay. Prolonged. Okay. About what is the cut? What is the normal range? First of all, it's +2 or -2. Okay, and the control here is 15. So if it's more than +2 or -2, if it's more than +2 and less than -2, that's the cut ratio. So for example 1, it's within the +2 -2, and this one is prolonged. The number 2 is prolonged. The difference is 4, which is longer than +2 -2, and for 3 as well, it's more than it's delayed. The control is 15 seconds, and the difference here is 4, longer than the cut point of -2. Okay, let's look at the APTT. The APTT, it utilizes a surface activator which activates factor 12 in the extrinsic pathway, and it uses platelet substitute of phospholipid and calcium chloride and plasma. In kaolin test, in the KCCT, the surface activator is kaolin, and in kefalin test, the kefalin is the phospholipid source. Okay. The reporting, it is reported in seconds. The control is shown in Q seconds, and the test is shown in P seconds. To assess the significance is to assess the integrity of the intrinsic pathway. Sorry, because of the factor 7, and monitor the heparin anticoagulant therapy. Anyone to comment on this test? First of all, the normal ratio is 35 to 45. Anyone to comment? For the for the first example, the test is 46 seconds and the control is 33. This one is prolonged very much. And the second one, the control is 35 and the test is 95. All of them are prolonged. Okay. For thrombin time is used to assess the fibrinogen levels. It uses the reagent thrombin reagent and plasma, of which all of them 1 volume each. Okay, it's reported in seconds as well, with the control being m seconds and the test n seconds. Okay, now let's discuss these values, the test done. The first one. The prothrombin time, 14 seconds. The control, 13 seconds. This one is it prolonged, normal, or within the normal range, or delayed? Remember we said it's a cutoff of +2, -2. Anyone? Okay, normal. Thank you, Ibrahim. The APTT, the test is 66 seconds and the control is 35 seconds. Okay, prolonged. Thank you, Salma. The thrombin time test is 9 seconds and the control is 8 seconds. This is also normal as well. And the bleeding time is 14 seconds. The IV is done. 14 minutes, I mean. What was the normal range for IVs? We discussed earlier. Okay, IV's test is 7 minutes. 1 to 9 minutes is the template, I think. Okay, the bleeding time is also prolonged. Okay, now let's discuss what were the causes of prolonged. The first prolonged test was APTT. What are the various causes of prolonged APTT? Anyone? Unmute, chat. APTT. Okay, problems with the intrinsic pathway. Okay, the intrinsic pathway. Remember how I remember APTT table tennis. The table tennis is played inside. Okay, indoors. Intrinsic. Okay, for PT, play tennis, the outfield. So the extrinsic. Okay, problems with the intrinsic pathway. For the intrinsic pathway, what are the factors involved? Farhia. Coagulation factors. Okay, factor 8 and factor 9. Okay, those factor 8 and factor 9 deficiencies cause which disease? Hemophilia, thank you. Hemophilia A, hemophilia B, hemophilia, because prolonged APTT. Okay, other causes we have Remember, factor 8 mainly is associated with von Willebrand as well. Thank you. Von Willebrand disease is also causes prolonged APTT. Other causes, any liver disease can lead to decreased production of the all factors. It causes prolonged APTT. DIC, lupus anticoagulant, and medications like heparin. Okay, let's change gears to, we discussed about bleeding time test, the causes. Okay, in this test, the only thing prolonged is APTT and bleeding time. Okay, bleeding time test, this shows that the primary plug is also defective. Now, what causes prolonged APTT and bleeding time? Anyone? Yeah, von Willebrand disease. Thank you. Thrombocytopenia will cause bleeding time, prolonged bleeding time, but the APTT will be okay. 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 Let's look at the second question. This one, the prothrombin time test is 20 seconds. The control is 13. This one is prolonged or normal, within the normal range. Remember, when you're given such a question, you have to comment if they are prolonged or within the normal range before you answer the question. Okay. Okay, prolonged. Thank you all. The APTT, the test is 75, the control is 32. Prolonged as well. The thrombin time, the control is 14. I mean, the test was 14 seconds and the control is 9 seconds. Okay, prolonged. Okay, we looked at the APTT test and the causes of prolonged APTT. Let's look at prothrombin time. What are the causes of prothrombin time? First of all, what do we use prothrombin time to assess, the intrinsic or the extrinsic pathway? Remember PT, tennis, the extrinsic pathway. Thank you. What are the factors in the extrinsic pathway? Factor 7, 3, and 10. Factor 3 and 7. What are the causes of low factor 7 and 3 causes? We have which vitamin? For factor 7 especially, vitamin K. Thank you. Vitamin K. And where are they produced? These factors, most of them? From the liver. Thank you. Any liver disease will cause prolonged both PT and APTT. Okay. And the DIC as well, prolonged APTT and PT. Causes of prolonged PT, we said vitamin K deficiency, liver disease, warfarin. Remember warfarin, the mechanism of action of warfarin? I know if you've done pharmacology. It inhibits which enzyme? To prevent reuse of vitamin K. Okay. So warfarin as well prolongs PT, inhibits vitamin K, epoxide reductase, I think. Vitamin K epoxide reductase. We'll confirm. And massive transfusion loss as well, prolongs PT. Okay, now let's come back to this example. It has prolonged PT, prolonged APTT as well, and thrombin time test. What are the causes of prolonged thrombin time test? Let's look at this. Thrombin time. Remember we discussed earlier, thrombin time test is used to assess which factor? Thrombin factor. So fibrinogen. Hypofibrinogemia causes prolonged thrombin time test. So anything that affects thrombin time test is hypofibrinogenemia. Anyone? What is the name of this spot? It is the blue top, yeah? Blue top vacuum container. It is used in the coagulation profile test. Yeah? What is the reagent it contains? Anyone? Hi guys, can you hear me? Yeah, sodium citrate, thank you. And the ratio of sodium citrate with the blood. So the ratio of blood and okay, 1.9, one ratio of 1 to 9, 9 blood and ratio of 1 for the sodium citrate. I think that's the last slide. Thank you. Anyone with a question?
Assalamu alaikum. Could you please
Wa alaikum salam.
could you please repeat the one you're talking about for direct and indirect Coombs test?
Okay. For this slide, this is the direct and the indirect Coombs test. I was trying to differentiate between the direct and the indirect Coombs test. For the direct Coombs test, we did anemia, especially hemolytic and the autoimmune hemolytic anemia. For the direct one, we use the direct test to determine the cause of the autoimmune hemolytic anemia. We use the patient blood as the test sample. We add the anti-human globulin. If the RBCs are sensitized with antibodies, they will react with the globulin to cause agglutination. If the antibodies are already sensitized, if they are already coated with antibodies, that will cause hemolysis, yeah, the agglutination. If they are not, there will be no agglutination. For the patient serum, remember when a patient is transfused with the blood, the antibodies are in the serum. When they are already exposed, they produce antibodies in the serum. So we use the recipient and the serum, which contains antibodies if they are sensitized. So we add the donor's RBCs, the donor's blood with Coombs reagent. If the recipient has the antibodies, it will react with the red blood cells to cause agglutination. If they are not, there will be no agglutination. That's the one of the use is in cross matching. Okay, it's one of the before transfusion, one of those tests done to show compatibility. Okay, you can. I don't know if I explained it easily or I made you confused further. Yeah, thank you. Well, any other question?
Excuse.
Okay.
Or can you
Hello?
complement? Hello, can you hear me?
Yeah, Oche, go ahead. Yeah, I can hear you.
I'm asking, can you complement the effect of fibrinolytic pathway on like bleeding disorders? Like
Yeah,
if you have excessive fibrin-
in the thrombin time test, or
yeah.
we said for the thrombin time test, we used to assess the state of the fibrinogen. Okay, you got me there.
Yeah.
Okay, what was your question?
Oh, like can you say like if you have a highly sensitive fibrinolytic pathway, it will affect like all like the APT time, prothrombin time, and also the thrombin time. Like the liver disease affects all of them.
Yeah, I think
All of them.
I think it will affect the thrombin time test. It will be prolonged because the other factors are already formed the thrombin time. I mean the PTT and the APTT will be normal, I think.
Okay.
If there are no other questions, I think my other colleague is ready to go ahead.
Hello.